Welcome, I'm Suzanne Phillips. Thanks for joining me again on Psych Up Live. Today we're talking about the care of foreigners, how immigrant physicians changed U.S. healthcare. While most think of immigration as the influx of people seeking shelter, survival, and a livelihood in a land of opportunities, this story is different. Today you will hear what unfolded when, in the face of a shortage of physicians in the U.S. in the late 60s, President Lyndon Johnson passed the Hart-Cellar Act, which had a special provision to supplement the physicians' shortage in the U.S. with a cadre of foreign medical graduates from South Asia and the Philippines to fill the vacancies, particularly in the urban and rural centers. In the first 10 years, 75,000 foreign physicians came. This show will bring you up close and personal to their commitment, their connections with communities, their contributions, and their struggle to be recognized. We are so fortunate to have as our guest Eram Alam, historian and Harvard Associate Professor, who will be discussing her new book, The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare. In this book, Eram Alam offers the personal challenges and psychological journey of foreign physicians who were welcomed to the United States as a solution to a labor shortage crisis in healthcare. Eram Alam, it is my privilege to welcome you to Psych Up Live.
Thank you so much, Sue. I'm really looking forward to the conversation.
Okay. Well, let me start by asking, what prompted you to write this book?
So, my family, little biography. My parents came to the United States in 1970, and my dad was an engineer. So he was a part of this cohort that was coming, but he was not a physician. He's outside of my study group. But I joke because every time I would go to the doctor, especially as an adult, people would assume that I was a physician as well. And so I kind of just, that would sit in the back of my mind. You collect these funny anecdotes of, oh, this person thought I was a doctor, this person thought I was a doctor. And I just sat with it. And then finally, when I entered into graduate school, so I was studying history of medicine, and I was really interested in health disparities. And I felt that, well, who's actually providing care in a lot of these instances where we're finding these health disparities in these communities where these health disparities exist? And then it kind of dawned on me, both of these things together. One, why is there such an easy association with South Asia and somebody who's Indian and physicians, and then who's actually providing the care in these communities? And it just kind of came together that, of course, these are immigrant physicians that are providing care in these communities, and they're so ubiquitous that even in this offhand comment that I keep hearing, people are associating me with this professional cohort. And so I thought maybe I should investigate what's going on here.
Okay, this is really interesting. Well, in the book, one of the people that you focus on is Dr. Nayan Seth, and he immigrated from the city of Pune, India. Did I say that correctly? Okay,
Pune.
Pune. And he struggles. He's enthusiastic, but his struggle and to adapt American ways is not easy because he hits the wall in the sense of he tries very hard, but he can't quite do what an American middle class white male physician can do. And so he has to really take on the challenge of recognizing that his presence and position as a physician to people, it's incongruous with what they expect. Um, and I think he heads out to areas that are in need of physicians, but he actually learns how to make his connection a safe one and an acceptable one. Maybe you can talk a little bit about that.
Yeah, so many of the physicians that I spoke with for this book were explaining to me that, there's so much about medical care that is multifaceted. So one is, of course, having this biomedical knowledge, but that there's this hidden script or there's this kind of tacit knowledge that also exists. And in fact, so much of that is a part of the day-to-day interactions of how people actually do doctoring. And so when these physicians entered into clinical interaction, they were found it difficult in that register of sociality, to figure out how is it that they have to move within a particular kind of space or the clinical interaction in order to be able to yield an effective therapeutic outcome. And so what they often commented on was there was an expectation that a white, often in this, especially in the 1965 period, there were white male physicians who were dominant on the scene, and they were afforded a certain kind of accessibility, of authority to the patient just by virtue of their social position and coupled with their professional identity. And that these immigrant physicians, they confused that kind of configuration because they're these non-white people with accented English, with this education from elsewhere, who are claiming to have the same expertise and authority as this figure that people are more familiar with, yet they're just completely different in how they are presenting. And so the physicians often talked about strategies that they used to, like you said, to gain that kind of trust. So, how is it that they sat in a room in a different kind of way? How did they use the skills that their colleagues may have had in one domain? Maybe they were better at English than they were, and they worked together in order to figure out how best to navigate a situation. Maybe they read the chart a little bit longer or asked questions in a different kind of order. You know, one case that really stood out to me and that I wrote about in the book is a physician who really had to think about how to touch because so much of doing the physical exam, I mean, all of the physical exam is about touch, and we take for granted that aspect of the exam, but in fact, we're allowing for a certain kind of extreme vulnerability in that, and it's based on the trust that is inherent in the figure of the physician. So if you don't trust that physician to have them touch you in these, very um, intimate, vulnerable kinds of ways, is something that these physicians had to actually really think about, that I think their colleagues, their US trained colleagues, often took for granted.
Mm. One in line with that, one thing I really loved is um, this doctor came up with the rule of you read the entire history and you go in talking, so the person already knows, oh, he knows me. He knows he's validating why I'm here, which is makes so much sense in terms of allowing that person's anxiety, because the people have anxiety about how they're going to tell what their medical problem is when he would come in from what he was saying and discuss it and then follow it, always, discuss and connect before touching. It seemed to me psychologically such a good idea. Such a good idea.
Yeah, and I think it's one we sometimes take for granted that, if you're not reading a chart at the moment that you're interacting with somebody and, oh, hey, your name is, okay, as that person is in front of you, and this is
Yes.
your complaint, just even having that sense of, it's a sense that somebody actually has done the work to pay attention.
Yes.
Um,
Yes.
and I think that already is a disarming thing for a patient, to
Yes.
feel in these moments of extreme vulnerability.
Yeah, yeah, to feel important enough too. Now, as you describe the book, you give many examples. We were laughing before the show that the doctor shows on TV are ridiculous. So one young man, my heart went out to him. He probably saw a doctor call a nurse honey on a TV show. So at one point he calls a nurse honey and she's like, what? So there were so many things in addition to their medical expertise that they had to come to know. But you could feel in the book as you wrote it, their urge and their wanting to fill that gap that we had in the US. These were urban centers, um, white males who were going to more developed areas to practice were not really going to these areas. And as you say, back in the 60s, they were mostly males. And so they really provided a very important service, the doctors who came. Now, in your book, it's kind of a cliffhanger at the end of that chapter. You say, but that would soon change. Now, tell us what you mean.
Well, I think that these physicians, especially as the years went on after this piece of legislation and more started to come to this country, there was this familiarity with this cohort of practitioner because they were in such huge numbers working in these urban and rural communities. So there were times where, um, on average, over the last 60 years, immigrant physicians have constituted a quarter of the labor force. But there were times where they were anywhere from 40% to 50% of the labor
Wow.
force per year. So this was not a small scale migration in terms of um, the healthcare physician labor force. And so what I think started to happen is they started to recognize that. And as more and more of them came and as they were able to connect in different kinds of registers, so they started to connect socially and culturally, I think they developed conversation amongst each other that there's something might be slightly awry that's happening with how we're being treated within the medical system. Because on the one hand, we're absolutely vital. We're being invited to provide this care that nobody else is providing in these shortage area communities in huge numbers. Yet on the other hand, we're still in this kind of precarious situation in terms of our employment possibilities, where we exist within the broader just landscape of the United States. And so I think that is what I gesture to in terms of, that there's a change that's happening, which is I think that there's kind of an awareness of the fact that they do have this really important power. And it's now up to them to figure out how they're going to harness that and what they're going to do with it.
Hmm. So, and I'll read it. So by 1980, the recommendation of the Graduate Medical Education of National Advisory Committee was saying that the number of graduates of foreign medical schools entering the U.S. needed to be severely restricted. And the reason was,
So 1980s, there was economic austerity that was happening. We're in middle of Reaganomics. Healthcare inflation is a really, really huge problem. There's general inflation that's happening in the economy, but the healthcare is seen as rising at a rate that's even greater than the rest of the economy. And so one of the ways of contending with this was to cut social programs like Medicare and Medicaid. And when this whole entire immigration system was orchestrated, there was a stipulation that immigrant physicians, their residency salaries would be paid by the US government under Medicare. This is true not just of immigrant physicians, but actually this is true of all residency physicians. And the reason the government takes this on is to make sure that you can stabilize that labor force. So no matter what the specific hospital is dealing with in terms of their economic outlook, that at least they can always guarantee that they will have
mm,
a stable and steady resident class. And
mm,
so the government subsidizes that in order to ensure the stability of that. So immigrant physicians became this scapegoating of them happened during this moment of medical inflation that maybe part of the problem of why Medicare is getting so big is that we're paying for the salaries of all of these resident physicians that are now coming in such abundant numbers. And maybe the solution will be to just stop their immigration from happening. Therefore, we won't have to pay them. Therefore, Medicare will not be the deficit will not be as high because the spending won't be as much. So
mm,
that was the thinking, and immediately there was backlash against that because all of these states and all of these local community hospitals came out right away and they said this will destroy us. because
Mhm.
these are the people that sometimes 100% of our whole entire physician workforce are immigrant physicians. So if this gets cut, we have no doctors to serve our patients.
Mhm. Now, the question is, so they began investigating this rhetorical shift from physical shortage to physician shortage to physician oversupply, which they were blaming on the foreign physicians. So at that point, um, another doctor steps up, and that doctor, um, the doctor who steps up to start doing some of the political work. Tell us a little bit about him and how he steps into this.
Yeah, so, again, there's this feeling amongst the physicians who are now socially connected to one another. They're starting to meet informally, and they start to exchange stories with each other about, what's happening with you, how are you feeling in your work, what are some of the issues that you're experiencing on the job, and they notice that there's a shift in how they're talked about, and they consider this to be a kind of political shift that's happening in the federal government, and that it's trickling down to them. So this kind of antagonistic relationship to their presence in the United States, they're saying, we're kind of experiencing that in the day to day in our work practices as well. And so perhaps we should do something about that. We should think about what is it that we bring? What is the importance of what we're bringing to this country? And how do we mobilize such that it's very, very clear to all of these government officials that we are absolutely vital in the backbone of the healthcare system? And so one of the things that I always point out in talking about this book is that this migration this is an elite migration that's happening. And so these people already have access to some resources. And then additionally, they've been working in the United States at this point for, anywhere from 10 to 15 years, and they're able to accumulate economic resources. And so they realize that in the US, one of the ways to get your issue or your political agenda to amplify it is through money. Um, and they have that. And so they start to use that in really strategic ways to support the campaigns of certain Congress people who they think will be sympathetic to their cause and will bring this issue of the discrimination that they're facing to Congress, such that some kinds of changes at the federal level can be enacted to ensure that these things don't show up in their day-to-day practices anymore.
Mm,
And so he just becomes really savvy in understanding how it is that you hire lobbyists, how it is that you have to speak to politicians, what do campaign contributions do, what can't they do, and just learning, I think he he's like, they had to learn the language of this whole entire process and of the whole entire system. And
mm.
they gained that fluency, which, is not just English. If you ever have gone into a court, I have no idea what they say. Or, it's a whole, or
Mm.
into medicine, in fact, it's a whole nother realm of understanding that they had to really develop a fluency in.
This is Dr. Shah.
Mhm.
Okay, and a good, I think an example of that is, so they're looking for a name of a coalition of Indian, Pakistani, Islamic, and Filipino doctors, and it's really powerful. They call it, so I mean, I think it captures, or is an attempt to capture the fact that they're legally Americans, but they come from many places. And, it is interesting, as you say, the way they get help to leverage political gains if they can. And Dr. Shah never seems to stop working on it. And sometimes um, what's a little bit sad is that, and maybe I wonder if you have some thoughts about this. I think at one point they were putting through a vote that They wanted to secure the same exams, licenses, and procedures for foreign medical graduates to match up with those of the American graduates. And they were successful in doing that. But the next thing they tried for was the idea of limiting the restrictions of the Medicare and Medicaid funding to hospitals with foreign doctors. And in that, you say they didn't get enough support from the foreign doctors. What do you make of that?
Yeah, I think, there are these tendencies always that exist within immigration conversations. And one is, what does assimilation mean? Does it mean that you don't voice your difference and that you just pretend that everything is the same and that over time it will eventually all be okay? And I think this is actually the position that many of the immigrant physicians took, that if we just continue to show the public, the medical establishment, what we do, that eventually they'll come around. And I think there's another position, which is no, that's actually never going to happen. Power will always reproduce in ways that they will be outside of the streams of power. And so it's about asserting your position and it's about asserting your rights, and I think that they really took examples of the civil rights. They took examples of the women's movement at that time to understand that, this rights are things that are, unfortunately, they're won. They're not always things that are granted. And so that they had to be much more aggressive in their assertion of their rights versus this kind of quiet assimilationist model. And so I think those are the tensions that were existing even within the immigrant physician community.
So I wonder if the hesitation is don't call undue attention to us. We are now seen as professionals. We're physicians, we're surgeons, etc. Let's not become, a group that is calling a lot of attention or presenting as having negative feelings toward American politicians, etc. It's a very hard line to walk.
Yeah, I really think this is one of the fundamental immigrant dilemmas. Is acceptance and legal entry into the United States, is it a gift or is it a reciprocal relationship? And I think for some of the physicians, they felt like, well, this is a gift and an opportunity. And so we don't want to complain in the face of that opportunity, while others recognized that this is not just a gift. We are, in fact, extremely valuable and we are providing these absolutely necessary services, that this is a reciprocal relationship. And
Mm.
so rights should be distributed to reflect that.
Okay, we're going to take a break. You've been listening to Psych Up Live, and today we're fortunate to be speaking to Eram Alam, historian and Harvard Associate Professor. She's been discussing a fabulously interesting and important new book, The Care of Foreigners, How Immigrant Physicians Changed U.S. Healthcare. Stay with us. We'll be right back. Welcome back to Psych Up Live. We're having a very important discussion with author Eram Alam. She's a historian and Harvard Associate Professor, and her book is The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare. And we're just in the middle of discussing who really, I think we mentioned it at the beginning when we talked about Reagan's um, decision to bring in immigrant doctors to help those areas of the country that were really in need. But we are still facing many areas of the country where there is poverty and there is tremendous medical needs that are being unmet. The people who are meeting those needs are immigrant doctors. And so my question, Aram, is at this point, what's the financial viability of many of the, you say, 77 million people are living in areas where healthcare is questionable or not that available. So, how is this being positioned? Is that making a difference in terms of preserving the training and care of immigrant physicians for these people?
Yeah, so unfortunately not. I mean, the 77 million people who live in shortage area communities in the United States, in urban and rural areas, are, as you said, often served by immigrant physicians. One of the most recent complications that they're dealing with is that there's what the physicians either come on J visas, J1 visas, or H1B visas. And the H1B visa has been recently targeted by the administration with a $100,000 additional fee for first-time applicants for this visa. And this is a special visa for skilled immigrants, especially to come to the country. And so this fee is supposed to be absorbed by the employer of the person who is coming. And what's happening, especially for these hospitals that are already operating on really thin margins, that the fee used to be $2,000 to $5,000, and now that it's gone up per visa to 100,000, this is going to be extremely cost prohibitive. So if
Mm,
you had, all of a sudden, if you have 10 physicians who are immigrant physicians on your staff, instead of having 20 to $50,000, now you need to have $1 million in order to pay for
mm,
their visa sponsorship. So a consequence of this is going to be fewer physicians able to actually join the staff of these hospitals, which means that already underserved communities are going to have even fewer physicians there to provide the care that they need. So, just to also remind your listeners that a shortage area is when there's one physician to 3,500 patients.
oh, wow.
And so, already that's the designation that 77 million people live under. And when we make it even more difficult for these practitioners to be able to come, then that the shortages are just going to increase, and those people who live in those areas are going to suffer even more.
Mhm. The story behind clumping immigration with drugs and many other really horrendous things, skews us and blinds us to a situation like this, where Americans would so benefit from more of these doctors coming, wanting to come, and being able to service thousands of people. When you think about what you just said, one doctor per 3,000 people, I mean, it's hardship. It's more than hardship. Really, it's almost unacceptable. So, when people talk about, and even probably when this is discussed politically, and you said before something I think really important. One of the things Dr. Shah, who's elderly now and has really contributed so much in his years, was trying to explain to the foreign physicians is we have to have a voice politically, or they won't understand what it is they're paying for. And now you're just making it clearer and clearer to us and to our listeners that a child somewhere in the Midwest in a small town is not likely to get care the way a New York City 5-year-old is going to get care. And that's an atrocity in some way if we used money to keep physicians out of the country.
Yeah, this is one of the really complex issues with this even whole language of a shortage because it's not as if all of the country is experiencing a shortage. I live in Boston and there's a surplus of physicians where I live. I
Hmm.
don't live in a shortage area at all. I live with many hospitals around me. Fine, I can't ever get in to actually see them, but they they exist right here. The
Right.
facilities are all here. So we live in a country where distribution is such a huge issue of
Mm,
how and where people are going. And we have surplus right alongside shortage in many
mm,
communities.
mm,
And so these shortage areas are really being served by the immigrant physicians because US trained physicians are wanting to come to places like Boston where they have the resources, where they have peers, where there are academic medical centers. They're not wanting to go to Tuscaloosa, Alabama, or to Kansas and Oklahoma and work in small communities. And so those communities are the ones that are also just really, really going to suffer. And they already have been dealing with geographic issues in terms of long distances that people have to go in order to see any kind of physician, let alone a specialist of any kind. And I think that if we don't start to pay attention to, yes, physicians, but just immigrants in general as being completely foundational to the fabric of the operations of this country, I think everybody else is going to really suffer.
mm. Now, one of the things in the book that I think Dr. Shah fights for is the same kind of training, the same kind of tests must be taken, parity across the board. And I think sadly there is a bias sometimes if someone thinks somebody's foreign, that they can't possibly know as much as an American physician. I mentioned, and I'll disclose it on the show, I owe my life to foreign physicians in terms of the surgeries that I've needed over the years. And it's it's very sad for us to even imagine that someone is would even question the level of care because of that person's background. And that's maybe a piece of also what happens in terms of legislation. An assumption that why should we pay $1 million or why should we pay $100,000? How good could they be? That's a very sad bias because think of the people who suffer on the in a small town out west.
Yeah, I mean, I think this is always the problem of American exceptionalism, thinking that everything here is the best, but in fact, we have a system where American citizens are the ones that are have such poor health outcomes in all of the metrics in relation to other developed nations. And so we have to start to ask questions about why it is that that is the case. And then again, for me in my work, it's like, well, who's showing up to handle all of these kinds of situations? But I think that there is some kind of assumption that, well, if education is attained elsewhere, it's not going to be on par, it's not going to be the same quality, because there's some idea that what is provided here is the best, the most universally applicable medical education. But I was just talking to a colleague of mine who said um, there's a talk at a grand rounds, and they had a case, and it was this complicated case that had taken these physicians 3 weeks to figure out. And there was a foreign physician who, and these were US trained physicians, and there was a foreign physician who attended this lecture, saw the case, and at the end of it, immediately was able to diagnose the situation. And what the difference was nobody was smarter than the other person. It was that in India, the cases of whatever illness that they were looking at are much more prevalent. So
Ah,
this person had this experiential knowledge that these US trained physicians actually just didn't have
oh, I love it. Yeah,
about
yeah.
this same kind of thing. So is that a matter of smartness, or is that just a matter of, again, this kind of experiential knowledge that people accumulate given the surroundings that they're in? And people are extremely malleable. So you put them in a different environment and they'll start to use that information as their input and start to make decisions that and so I think we need to start thinking also about that, like kind of the flexibility. They have the educational background and they have the ability to be agile and flexible thinking people when they're doing their jobs, but that's not always assumed or given.
Hmm. So from what you can tell at this point, what what did you really came to know Dr. Shah, and he was maybe an early um, in the forefront of fighting, of really fighting for foreign doctors. At this point, how do you see the situation in terms of what could possibly happen, what he made happen as a result of his efforts, and what has to continue to be worked on?
Yeah, I think he was really an integral figure in early political organizing and did the work of turning this into an issue. So as you mentioned, fighting for the exact same exams, for example, so that that was not something that people could use to discriminate against immigrant physicians, that, okay, well, you don't have the same exams, therefore you are not as good or qualified or competent. Um, but I think that after he and his colleagues did their political organizing work, I do think that there has been this ascendancy of this figure into popular media spaces that has really, in some ways, created these two different spheres, these two different tiers. One in which we're fully willing to accept this practitioner in the form of the national health expert, in the form of the TV character. Yet, at the same time, we still continue to have this xenophobia that exists around the kind of labor that these practitioners are bringing. And I don't know if those will ever get resolved because one looks at the first one that if you have all of these people who have clearly proven themselves um, to be successful and to be doing the work, then when will the situation get better? But I think it ultimately points to general xenophobia that is really present in national politics writ large, and that it's not directly about these physicians and what they can do and their competence levels, because all of the studies show that they have fewer malpractice cases than their US trained colleagues. Patient satisfaction is on par or higher. Yet there's still something about their foreignness that continues to kind of disrupt all of these statistics that show that they're really excellent practitioners.
Hmm. I hadn't thought of it before. Of the group of foreigners who come, are the majority male and there are very, very few females?
So in the beginning of the migratory flow, it was about um, 90 to 93% men who were coming. And after that, so there are two stipulations in the Hart-Cellar Immigration Act and Nationality Act. So one was around skilled migration, and then the second category was for family reunification. So often what happened was first these physicians would come, and then their female partners would come afterwards. And so there was a little bit of a lag in the female physicians coming. And then they just also didn't always have the same kinds of opportunities in country of origin. But you started to see the shift probably in the late 1980s, where more women were being educated in South Asia, in the Philippines in general, and then they were also starting to come. So it's a little bit of a lag, but you're right to point out there was a heavily gendered nature, especially to the beginning of this migration.
Well, I was thinking you had mentioned that people kept asking you if you were a physician. Um, and so now it's probably not 50-50, but as you're saying, many, many more foreign female physicians.
Yeah, and in addition, I think what's happened is for people like me who are first generation who are born here, there is actually an overrepresentation of South Asians in the medical field as well. And so I try to think about that as well, that vis-a-vis the population, they're far more than you would expect there to be.
Okay. Okay.
And so I think that's part of what's happening is that, but I think it's rooted in this migration, that because this is a physician migration, people often will continue to do the profession that they feel most familiar with. You know, these are the
Hmm.
choices that they end up making. And so we see it now show up generationally as well. I didn't
Uh-huh.
make that choice, much to my mother's chagrin, but nevertheless,
Okay. Well, now, based on, do you have the feeling, because you worked closely and you say he's very elderly now, that Dr. Shah is left feeling he didn't accomplish what he wanted to? Because one of the things you say in the book, and the book, I really encourage listeners to read it. It's so well done. You describe him having all these folders, all this material that he can't give up. And I can relate to this in some ways. But what do you think this man actually, do you think he recognizes the accomplishments he made in this journey?
I think he does. But I think what I try to get at with his case and the holding on to stuff is that one's position as a non-white person in the United States is always an incomplete position, and that your profession can allow you entry to a certain extent. The length of time that you've been in the country can give you certain kinds of cachet, but there is always this reminder, and we see this in political moments where, you know, things all of a sudden feel like they erupt into things that you didn't expect would happen. But they're always sort of these reminders of who is a part of a nation and who is not, are always percolating right underneath the surface. And so I kind of read this as that is, you know, yes, there is a sense of accomplishment, but it's tenuous.
Okay.
And that physicality is to me represents that tenuousness.
Okay, so we're just about out of time. If I were to say, what is a take-home message you'd like to share with our listeners?
I would just like to remind them that immigrants, period, are absolutely foundational to the operations of the United States, and that immigrant healthcare providers are in that cohort. They are the ones who are working in the primary care fields, often in family medicine, in pediatrics, in internal medicine. They are on the forefront of medical care in this country for so many millions and millions of people that are the most marginalized. And we need to start paying attention to how this cohort of people are treated because and start to value the kind of care work that they're providing.
Perfect. Now, where can they find your book? Where can our listeners find the book? I'm going to hold it up. Okay, here is the book. It's lovely. And where
Uh,
can they find this?
they can find it at the Johns Hopkins University Press website. It's also will be linked on my website, which is my name, ERAMALAM.com. And I think probably on Amazon as well.
Okay, sounds good. I want to thank you for coming on. It's such important work that you've done. I want to thank my listeners. Please remember you can hear this and any prior podcast on my host site, on the podcast app of your iPhones, iTunes, Stitcher, Apple Podcast, Alexa. You can see us on YouTube. Remember to drop me a comment or a question at suephil@optonline.net. Until next week, thanks and be listening.